Hi, good morning, everybody. This is Anna Ricklin with the American Planning Association, and we are here today to talk about health equity as part of the Plan4Health project. Thanks for joining us. As usual with our webinars, we have a Q&A box to the right, and you should feel free to add in any questions there that you come up for you during the session, and we'll answer them at the end of the presentation. I'm joined this morning by Shawn McIntosh, American Public Health Association, and she's going to give a longer presentation about health equity and the role that health equity should play in our Plan4Health projects and all the work that we do between planning and public health. So with that, I will let you know, of course, as usual, that our webinar is available on APA's Plan4Health website. It will be recorded and archived there. And we have a quick agenda today, or a simple agenda rather, today, talking about a quick overview of Plan4Health. We actually have a number of people on the line who are from organizations other than the APA's funded Plan4Health Coalition, so welcome to you. I'm excited that you could join us. And we'll talk about health equity and then have a discussion between myself and Shawn and have some Q&A with the audience. So a brief overview of Plan4Health. We are a new and emerging community of coalitions working across the country where we envision the full integration of planning and public health work at all levels, where people live, where they work, where they play. And our focus in particular is on nutrition and physical activity. So we're looking to improve the food environment and increase opportunities for physical activity. But throughout all of that, we are also looking to help improve and promote health equity and the opportunities for equitable access to healthy living. The core values of Plan4Health are cross-sector collaborations, really anchored by planning and public health professionals, but a number of other sectors, transportation, nonprofit organizations, advocacy, parks and recreation, the food sector, the nutrition sector, and bringing together member expertise of APA and APHA to build capacity to implement policy systems and environment change. And we can talk more about what policy systems and environment change is as we talk about the social determinants of health and the social, environments in which people grow up and live out their lives. I wanted to include here a sort of definition of health equity or health inequity and where it comes from as it's been defined by the World Health Organization on their social determinants of health. This is not super old definition and conversation about health inequities, talking about how they arise from circumstances in which people grow up, live, work, and age, and the systems put in place to deal with illness. The conditions in which people live and die are in turn shaped by political, social, and economic forces. And they really are not just the forces that cause you to go to the doctor when you're sick, and if you even have access to going to the doctor when you're sick, but really these larger forces in which you live out your life, where you grow up, and who you're born to. So thinking about that, I wanted to give folks a little bit more of a personal introduction to me. I'm currently managing APA's Planning Community Health Center based in Washington, D.C., but prior to this, I worked in Baltimore City at the Baltimore City Department of Transportation. And prior to that, I was in graduate school for public health. And when I was living in Baltimore, I really had an eye-opening experience to thinking about health equity in ways that I'd never had before. I was in graduate school looking at, thinking that I wanted to learn about how to teach people how to eat better, teach people about exercise, basically the field of health education and health promotion. But I was living in a city that I increasingly noticed was incredibly segregated, incredibly inequitable in terms of the access to resources that different populations had. And many people know Baltimore recently, especially because of the, it's been in the news a lot for equity issues. And those issues really are noticeable when you are looking at health and the health outcomes that the different populations in Baltimore experience. So Baltimore has a large population of people living in poverty, mostly African American. And when I was living there in my mid-20s and thinking that I wanted to teach the world how to eat better and exercise more, and then they would be healthy, I was looking around in a place that even I had trouble getting around without having a car, and relying on public transportation, and relying on unsafe bikeways to get around on bike. And thankfully I even had access to a bike, but I noticed that many families didn't have access to that form of transportation and were entirely reliant on a very disconnected and poorly serving public transportation system, to put it mildly. And I decided at that time that I wanted to begin work in the field of transportation to try to meet the needs of people so that they could have better access to healthy food, so that they could have better access to parks, and so that they could have better access to medical care, which in a city with disconnected services and disconnected public transportation was very difficult for many people. And so I put this slide here, this image here of the social determinants of health, which many of you have probably seen, because that we were working in this framework in the field of public health, but looking just at people's choices and lifestyle, I thought was really downstream for how we could best serve the entire community and the entire population. So thinking about the social and physical determinants of health that entire families, and starting at a young age, children growing up, what is the context in which you're growing up? And if you don't even have physical access to parks, or if you don't have physical access to grocery stores that sell healthy foods, then your choices are going to be immediately limited and not able to make the right choices for your own health. So let's just give some context about me, and I'm sure many of us in the Plan4Health world have also come to that conclusion themselves. But I think it's good to bring it back to yourself sometimes and think about what does health equity mean for you, and then the populations that you're serving. So with that, I wanted to talk about CDC's twin approach. This was impressed upon us from the beginning of our project in the national organizations, to think about how we have a priority to advance health for all, but we also have this priority to advance health for the most vulnerable. And how do we put together these two priorities? And that's where the strategies of the policy systems and environment approach, I think, is really great for the Plan4Health project and our sister projects at the American Heart Association and the National Women, Infant, and Children Association, as we think about improving health for all, but specifically helping raise the bar for, or raise the quality of life for those who are most vulnerable, those living in poverty, people who have experienced discrimination their entire lives, women with young children, people who have the most difficult access getting to healthy foods and opportunities for physical activity and safe environments. So as we're thinking about strategies that reach the entire population, and we're thinking about reach and what is our high reach numbers, also thinking about supplementing with some very specific strategies, which most of our Plan4Health coalitions are doing. So this is our little promo slide. I know most of you have looked at our website, but in case you haven't, that's our website and our hashtag. And now I want to pass it on to Shawn McIntosh, who's the program manager at the Center for Public Health Policy at the American Public Health Association, and helped really structure the Plan4Health project from the very beginning, and thinking about what our priorities would be, and thinking about a focus on health equity as one of the core tenets of the project. So I'll pass it on to Shawn.
Thank you, Anna. Good morning. This is Shawn McIntosh. I'm a program manager at APHA's Center for Public Health Policy. Interestingly, prior to working in public health, I worked for 15 years in community development in Baltimore City. Anna and I did not know each other then. We did not work together then. My focus was on improving the lives of low-income families and children in very low-income communities, primarily minority communities. It was during that time that I became acutely aware of the need to first address the health needs of individuals and communities in order to improve their overall well-being. Health is defined by the World Health Organization back in 1946 as a state of complete physical, mental, and social well-being, and not merely the absence of disease or infirmity. With that definition, that means that there are entire communities that have never had the opportunity to be healthy. Population health is the health outcomes of a group of individuals, including the distribution of such outcomes within the group. Addressing individual health and health behaviors is not enough because of inequities and barriers to access and health opportunities that perpetuate individual health disparities. Population health strategies can remove those barriers and inequities. That's why we designed Plan4Health the way it's designed. So what is health equity? Health equity is the principle underlying a commitment to reduce and ultimately eliminate disparities in health and in its determinants, including social determinants. Pursuing health equity means striving for the highest possible standard of health for all people and giving special attention to the needs of those at greatest risk of poor health based on social conditions. This was Paula Braverman's definition in 2014. I highlighted giving special attention to the needs of those at greatest risk of poor health based on social conditions, because I took a look at all of the coalition descriptions before preparing this webinar, and it was very clear to me that although I know that all of the coalitions have the intent to include equity in their projects, there were only one or two that explicitly talked about equity in their descriptions, which told me that you were all looking at this as a given. Of course, it's a given that equity is there because you're addressing chronic disease prevention. Obviously, it's equity, but it's not obvious. You have to be purposeful. Health inequity is truly a social justice issue because the social and physical determinants of health have been historically unequal in low-income and minority communities. Understanding the relationship between how population groups experience place and the impact of place on health is fundamental to the social determinants of health, including both social and physical determinants. Examples of social determinants include availability of resources to meet daily needs, access to educational, economic, and job opportunities, access to healthcare services, quality of education and job training. Examples of physical determinants include natural environments such as green space, built environments such as buildings, sidewalks, bike lanes. By working to establish policies that positively influence social and economic conditions and those that support changes in individual behavior, we can improve health for large numbers of people in ways that can be sustained over time. Improving the conditions in which we live, learn, work, and play, and the quality of our relationships will create a healthier population, society, and workforce. There's a process. There are steps that you can take to improve equity, and there's a process to weave it into your projects. The first step in that process is to acknowledge that equity is more than any one single intervention. I love this graphic because it really shows the difference between equality and equity. It wasn't created by us. It was created by the City of Portland, Oregon, Office of Equity and Human Rights. Equality is giving everybody the same. Equity is giving whatever is needed to give everybody equal access. Making a purposeful shift toward achieving health equity forces us to consistently view health status within a larger context of society and history, and will ultimately bring public health further upstream than it's ever been before. While each intervention must strive to provide equitable access or equal footing for all, it's very important to make sure that in seeking equity, conditions aren't created that have unintended negative consequences. Health impact assessments are one way of ensuring that no harm is being done. Making sure that partners representing multiple sectors and the community are involved in decision-making is another way of avoiding unintended consequences. In this picture, access to an equal view of the ball game is provided. What if some of these children go home to communities with ball fields where they can play Little League and some don't? Has a situation been created where something else becomes unattainable? Perhaps additional steps need to be taken to provide opportunities for the child without community ball fields to play Little League in his own community. If your policy intervention is to have bike lanes pass through low-income communities with the idea that you are creating active transportation and opportunities for physical activity, but you haven't worked directly with the community to determine whether or not they have access to bicycles or would even feel safe riding bikes on the streets in their neighborhoods, then you could be creating something that will create further inequities. Maybe the community would prefer safer, well-lit sidewalks and walking paths. Whatever your intervention is, you must also be purposeful in articulating it. I already discussed that a little bit, but it really does need to be evident in your Plan for Health descriptions. While it may seem obvious that an intervention designed to ultimately prevent chronic disease has equity implications, it's not. It may have implications for improving disparities, but where is the explicit equity? Articulate it. Use equity language. Number 2, have an open and honest dialogue. In many ways, this is actually number 1. It really is number 1 in the process because you have to start talking about the structural inequity, the structural basis for inequity. Start a conversation in your agency and ideally across your partner agencies about racism, bias, and inequality and how they contribute to disparate health outcomes. Use an icebreaker, such as the documentary Unnatural Causes, Is Inequality Making Us Sick? And make sure you tailor the event to fit your audience and create a respectful environment. Talking about inequity is not always a comfortable exercise. In fact, it can put some people on the defensive. But it is vital to gaining buy-in and shifting the focus from traditional disease prevention to tackling the social determinants of health. Other good resources for getting the dialogue going include Roots of Health Inequity, a web-based course for the public health workforce, which was developed by the National Association of County and City Health Officials, or APHA's webinar series, which is still going on racism in health. These resources and others can be found on APHA's website, www.apha.org. The link will be posted later in the webinar. Be willing to really look at the root causes of inequity in the communities you are serving. If you are only looking at the health disparities data and not the inherent structural causes through a lens of race, power, and poverty, then you may miss out on an opportunity for sustainable change at the population level. Partner, partner, partner. I know that you're all doing this. You're all partnering really well. It's important to really get out of those silos. One of the reasons we've been doing this work to create cross-sectoral collaboration is because traditionally we have done things in a very siloed approach. And it is important to really break down those silos. Get out of your own fishbowl. The reason I use these pictures for a very specific reason. The picture with the hand and all of the fingers with the different bubbles is really to represent that every single partner contributes to having their own individual thoughts and creativity. Make use of that. Transportation, housing, healthcare, employment, environmental quality, working conditions, education, childcare, law enforcement, all of these sectors and many more have a role in creating the conditions that enable all people and communities to attain and sustain good health. It is essential for these sectors to begin moving from a siloed approach to a collaborative approach in order to achieve equity. Partnering enables you to tap into the many talents and creativity of others. While partnering, it is essential to view all partners as having something valuable to bring to the table. Every partner has something of value. To achieve equity goals, it is essential to set aside egos and individual agendas, and you must continually ask, who is missing from the table? Who's missing? Be mindful of history. The picture is not there. There was a photo here of migrant workers protesting, boycotting Safeway, which is a very significant historical event. I'm sorry the picture isn't showing for you because it was just a photo to show you that every community has historical trauma in some way. Anna was talking earlier about Baltimore's deep segregation, that it is historically segregated, and there's a lot of trauma there. Achieving health equity requires an empathetic approach that acknowledges a community's history, respects its traditions, listens to its stories, and actively engages its members as leaders in any health equity intervention. Government and public policy played enormous roles in perpetuating the very biases, injustices, and inequalities that created the health disparities and inequities we seek to address today. Be aware that many communities are still experiencing the effects of historical trauma. As a public official or an outsider, coming into such a community with a predetermined plan and top-down approach only perpetuates that trauma. That is why it is essential to go into the community with an open mind and listen. Listening is the best thing you can do. Let go of your agenda. Really don't go in with an agenda if you can help it. Avoid going into a community that has a long history of experiencing health and social inequities with a predetermined agenda. Instead, go in with an open mind and simply listen and learn about the lives of the people you serve. This may throw a wrench into all of your preconceived plans and force you to go back into the drawing board, but that's okay. Achieving health equity may mean taking as many steps backward as we do forward. Suppose your coalition wants a safe routes to school program, but the community doesn't let the children walk to school because of issues like too many vacant lots, broken streetlights, and highway overpasses. What if their biggest priority is simply creating safer streets that they can walk on as families? What if you're not going to change the culture of not allowing children to walk to school? It's important to meet the community's needs and create win-win situations. Find out what their priorities are. It might be cleaning up the trash and rat issue before anything else. That may be their priority, and that's okay. That's how you build trust, which is really important. When you create those win-win situations, you are building trust in the community, which is essential to sustainability. Trust is the foundation of all health equity work. In fact, it may be the only starting point that will lead to sustainable progress. Building trust requires having an open mind, being flexible, listening to people's stories, respecting and integrating traditional ways, engaging in community leaders, and empowering people with the means to seek change for themselves and their communities. To build trust, you have to let go of turf, or what I really think is ego. Be willing to share resources and share the limelight. It doesn't matter who gets credit for success in the end, because success is shared by all. I chose this image of the collaboration continuum because if you look at it carefully, I think that often we start out in collaborations competing with one another. It's very important to let go of those things and to move towards really being fully integrated in your programs and your planning and your funding, because then you're truly sustainable. It's hard to get there. It's truly difficult to get there. But the way to do it is to share your resources, to let go of that ego, and to have a common vision and work very carefully with the community and build that trust. Follow the data, but you all have data on health disparities. You all know what it's telling you. But achieving health equity means allowing community values and priorities to shape and inform interventions. Science-based evidence is always important to measuring needs and progress, but gaining community buy-in is critical to sustainability. So your data might be telling you that the community needs a new grocery store, that they have no food access, but that may not be their priority. And so once again, this goes back to creating that win-win situation so that you can get there. If you really listen to the community and have the community buy-in, you can get there. It's a process, and you might not get what you need and want right away. Allow your project to be nimble and responsive to community needs. Find ways to help the community get what they want and need. If they want safer streets, do you have public safety officials on your coalition who can work with them to achieve public safety goals? That goes back to the who's not at the table. If you're listening to the community, then you know who needs to be at the table. Community ownership is paramount. Community participation is intrinsic to health equity work. I've been saying this over and over and over again in many different ways, but it really is the linchpin. This is probably a no-brainer for you, but the engagement is fundamental to public health work. Ensuring that community is involved in every aspect, from data gathering to implementation to evaluation, is key, and there are multiple ways to involve community. Make sure community leadership is represented. It's not always leaders of the neighborhood association or the local community organization. Listen to other community residents and find out who is respected and should be at the table. If your project targets youth, do you have youth involved? How are you involving the community every step of the way? Be mindful of that. Articulate it, write it down, write it into your goals and objectives. Pay attention to the process. This is really how you embed equity into your project and make it sustainable. And you make your coalition sustainable by paying attention to the process. The process of developing strategies to create health equity is as important as, and sometimes even more important than, the actual initiatives. If you can create a process for developing interventions that is truly community-driven and founded on trust, you have a better chance of sustaining momentum on the long journey toward health equity. This goes back to the collaboration continuum and all of the steps we've discussed so far. If you're using this process, creating strong partnerships built on trust, listening to the community, assessing needs, creating a shared vision, priorities and goals, etc., all of this, then you are embedding a culture of trust that will sustain your efforts and your coalition beyond the initial project. That is really what we intended when we wrote this. We didn't hope that you would get funding for a couple of years to do an intervention and go away. What we had hoped was that you would create a coalition that would be sustainable well beyond the funding of these projects. Know when to step aside. This is empowering the leader in all of us. You may have very strong leadership among your public agencies, But despite your skills, experience, education, and competencies, you might not be the best person to implement a strategy to create health equity on the ground. You might not be the person the community is going to listen to. Many successful health equity efforts recruit and train workers from the community who have the same lived experience as the residents you are hoping to reach. Keeping this in mind will help build trust, community ownership, and sustainability. Know your audience. Know who they're going to listen to. And if it's not you, then make sure you have somebody they're going to listen to delivering the message. You can find resources for equity work that will help you embed these processes into your interventions at www.apha.org/topics-and-health-equity. I'm going to leave that up for a moment. It's a great place for resources. We have a publication, Beyond Health Equity. There's a discussion on how we achieve health equity in our lifetime. This publication from Paula Braveman. The Determinants of Equity report from Seattle-King County is on there. Seattle-King County has done a tremendous job of weaving equity into their work. The Roots of Health Inequity, a web-based course. I talked about that earlier. It's a great resource. Equity and Empowerment Lens. It's a Multnomah County resource that actually walks you through using an equity and empowerment lens for policy interventions. And then, of course, Healthy People 2020 is a very good resource as well. We also have a Health in All Policies guide for state and local governments. I put this in here because it's really, truly a great guide. And you really are doing Health in All Policies work. That's what you're doing. And the 5 key elements of Health in All Policies work is to promote health, equity, and sustainability, support intersectoral collaboration, benefit multiple partners, engage stakeholders, and create structural or process change. And that's what you're doing. It's a great resource. You can find that resource on our website at www.apha.org/HIAP. With that, I thank you. And I think we're going to have a discussion now. Is that correct, Anna?
Yes, yes, yes. Thanks, Shawn. That was wonderful. I really appreciate the thoughtfulness of this and how we can follow some of these steps to really think about the community engagement and trust and the longevity of the project, because I think what you said towards the end there with our intention is not to have folks simply work for 15 months and then disappear, but I think all of our coalitions are beginning to think about sustainability, and thinking about health equity as being a core element of that is critical to actually improving health across all populations in the places that we're working. And we also know, one thing I'd like to talk about is, you talked about how it's not necessarily a quick process, and we are, especially when we're thinking about planning strategies and policy systems and environment approaches that are essentially trying to shift the social paradigm of what are the social determinants of health and improving the environment in which people grow up and the choices that people have from a very young age to access the economy and access education that all we know have very strong health impacts over the long term. But do you have, since you have a background in working in social justice and social change, do you have any other tips to help us think about maintaining energy over the long term as we're working on some of, even planning on its own is a long-term process, and then thinking about social change mixed in with that is another long-term process. Do you have any thoughts about keeping inspired as we're working on this and continuing to engage communities, some of which might be difficult to engage at the beginning, and maintaining that outreach?
Yeah, I think it's really important to make sure that you are not going into a community, gaining their trust, and then leaving. And if you keep that in mind, that you are building trust with communities, and you don't want to destroy that trust by just leaving. And so it is not any one single intervention. That's why that was the first slide. It's not just one intervention. So you may have this agenda of one intervention, but health equity, if we are to achieve true health equity, is it's so much more than one intervention. And so as you are working on your intervention, really identifying other needs and other things that can be done and creating more of a long-term vision. And it may not be your agency that does it, but making sure that the right partners are all at the table and assigning responsibility and taking ownership of those things. You may be concerned about funding, but truly, if you have that vision and a plan, you have then something that you can seek funding for. Mm-hmm. So it's much easier to get funding for something that is planned out and you have a vision for than to seek funding based on what the funder wants.
I'm wondering also if you could talk more about the difference between equality and equity. I know you have that slide that some folks might have seen before about how, and this goes back to what I was talking about with CDC's twin approach, is we do want to improve health for everybody. We know that chronic disease is reaching all levels of our population, wealthy and unwealthy, but particularly hard hit in low-income populations and populations of color in our country. And so how do we explain it to decision makers about the difference between equality and equity? Do you have any ideas about that? To reaching people who have more power potentially to distribute resources to really work on equity versus equality?
I think it's a great question, and it is hard to explain to decision makers because decision makers are concerned about their constituents. And so how do you frame it to them in such a way that you are really talking about their constituents? In the end, we have to look at how we are improving things for everyone. And so you have to share you do have to share data to show how things are impacting minorities to a larger degree than others, and that's where we need to start in order to improve things for everyone. You know, the costs that are involved. You know, decision makers are concerned about costs, and if you can show savings and return on investment, those are things that are very important. And there are studies that have shown return on investment and how if you can improve health in one area, you have investment savings in another. And so using that to talk to your decision makers is important.
The last question I'm going to ask, and I encourage folks to type in some questions too, to think about, to ask Shawn or myself, is about the cross-sector collaboration, which is the core of the Plan4Health project. And I like to think of us as agents of change too, by even just bringing together planning and public health through the Plan4Health project, and through the work we're trying to do through the collaboration between APA and APHA. But are there any particular sectors that you think people should include in their coalition, or that are really key for reaching, for talking about equity and reaching some of our equity goals? Or is it really truly just dependent upon the combination of needs in every community?
I think it has to be community responsive, and you have to look at, what is the community you're trying to reach, what is the community you're serving, and is your coalition reflective of what you are trying to achieve. Is your coalition reflective of the community you are serving? You know, when I was working in community development, I was brought into, I won't name the organization, I was brought into an organization who had built a facility that in a suburb that was primarily Caucasian, but right around the corner from a low-income African-American community, with the idea that they would be serving that African-American community. They were not serving the African-American community. People were not coming in to use their services. And they had me come in to talk to the board about ways that they could change that and attract the African-American community. And I went in and I walked around the facility to see what was happening and what might be a barrier, and there wasn't a single African-American staff member. And then I sat down to talk to the board, and there wasn't a single African-American board member. And my first recommendation was, you need some diversity on your board, and you need a diverse staff. You have to create some level of comfort if you want people to walk through the door. And the same goes for, you know, if you're creating a coalition that's serving a minority community, if it's a Native American community, you must have Native Americans on your coalition. If it is a Hispanic community, you must have people representing the Hispanic community on your coalition. You must have the community that you're representing, the community you are serving represented. It's essential. I mean, to me, that's 101.
Thank you. So I'm wondering if anybody else has any questions that you are interested in hearing about this topic. And this is the first in I hope to follow up this webinar with a couple of other webinars over the course of the year to talk about health equity, and maybe we could think about diving into some particular elements or particular topics more, like what is health equity for housing, what is health equity for transportation, what is health equity for particular populations in the future. But thinking about this introduction of the topic, we would be happy to talk about more things. And of course, we'll have this recorded so you can share this conversation with your colleagues later as well. Shawn, do you have any further thoughts of other things you didn't include in your slides but you wanted to talk more about that we have a little bit of time to think about right now?
You know, I know I said this earlier. I really do encourage the coalitions to take a look at their descriptions and maybe revise them to be more explicit in the language they use about who they're serving and why, what their interventions are trying to achieve in terms of equity, because there isn't really very much language that's explicit about what their equity interventions are. I think that's really important. If you're not explicit about it, it may not happen.
Yeah. No, it's true. We need to think more about that, and you know, it even needs to start with us at the national organization level, and think about how we're speaking about health equity and modeling that for everyone else, because it is one of the core elements of our intentions of the project. So I saw a couple of questions come in. One was talking about working with volunteers and how to maybe include volunteers as elements in the coalition work, or as people who are an important representative for representing equity potentially.
Yeah, absolutely. I think that you know, we talked about utilizing the community. Depending on what you're doing, there, you know, in the assessment phase, you may want to use volunteers to do maybe photo voice with the community. There are so many things that you can use volunteers in a creative way where they feel involved and they feel like they're doing something interesting and important that contributes to the end goal.
And thinking about that, kind of going back to what we were talking about before, what is, and when we were talking about the board and the staff of that organization that you were talking about that were all white and serving a very different population who looked different from them, how do we, this is a really complex question, but how do we better understand privilege of the people who are leading these projects who have greater privilege than some of the populations that they're trying to serve, and kind of struggling with that? I guess that's what I was thinking about at the beginning when I was sharing something about my own career and development and how came to this, you know, from a position of privilege to looking around me and thinking about trying to help others, but sometimes having a difficult time relating to the population that I see the need for.
Right. Well, this is where the whole discussion and having that the initial discussion about race and power and structural bias that has in the history come into play. It's really important to have those conversations and to help people to really look within themselves and identify their own personal biases, their own privileges that they're not even aware of. You know, when I was talking about, you know, if you're creating bike paths in a community where, you know, the community might not even have bikes, was that something that we were even thinking about? And was that a conversation that anyone had with the community about how the community would access the paths, whether they even wanted them? And it may be one or two people in a community who think, oh yeah, bike paths would be great because they have bikes. But then there might be, you know, 95% of the community that don't. And so you're creating something that then isn't even really wanted or useful. And how do you get to that information?
Unless you maybe are also working with folks to get bikes to that population.
Yes. See, then that's where you have the unintended consequences and how do you fix it. If you then realize, you know, oh, there's not even access to bikes. However, there's a bike store that's willing to create a bike share program or something like that. Absolutely, there are ways that you can fix that, but you have to be aware.
Mm-hmm. And the filter that we're using might have a different set of priorities built into it than what the community might need.
Right, exactly.
Well, I think we've talked about lots of things, and we have about 10 minutes left, but I see no reason to continue if we don't have any more questions coming in. So I might just decide to end the webinar here. And
oh, there's a question.
Oh, there is a question.
Okay.
Sorry about that. The question is, would you talk a little bit more about your experience with labor health inequity, where workers are not protected from secondhand smoke in casinos and bars, but are...
Well, that is a great question. It's not something that I am specifically familiar with. However, that is clearly an issue. You know, there are examples of working with workers to organize around an issue and to help them get workers' rights. It is certainly a workforce issue. There are ways to work with workers in an industry to help them get their needs met. And if that's the project that you want to take on, that is certainly something that you can rally a community around, and your coalition can actually help communities advocate for themselves. You can help communities learn how to advocate for themselves. That is certainly something that you could do.
Yeah, and I think this actually goes over into very, related areas. There's a number of different, thinking about the bigger picture of the social determinants of health and the economic opportunities that different populations have, and if the only jobs available to you are jobs where your health is at risk in any type of labor job, but many other kinds of jobs as well, that your health might be at risk, then I think that goes to also speaking about what those people see as priorities in their community for to address. So they definitely, the priority is like being healthy when you go to work versus, where's the grocery store?
Right. And in a situation like the secondhand smoke, if you're working with your public health department, you can also look at asthma rates, hospitalization around asthma, lung cancer rates, and things like that, to use that data to frame your interventions and your argument with your decision makers.
And fitting all those pieces together.
Yep.
Great. Well, thank you, Shawn, for joining us.
Thank you.
Like I said, this is hopefully the beginning of a conversation that will continue over the next year and 2 years, and the life of our project, and on into the future as well, as we consider health equity to be a core value of the way that we're approaching the cross-sector work between public health and planning, but also any other sector that we know is important to include here. And I think we've all got a lot to think about after some of the talking points that you brought up and some of the discussion topics as well. So thank you, everybody, and please be in touch if you have further questions, and we will be posting the webinar so that you can click on any of those resources that Shawn shared, and I highly encourage you to look at them. Have a good day.